the heart failure, mainly it's basically a clinical syndrome, of course. So it's a syndrome of symptoms, not like only one. Um, is this working? Yes. So it's a clinical syndrome, not only one type of symptoms happening, but there is a collection of symptoms and things that are occurring within the patient's body. So it's called the clinical syndrome. Basically, the problem is of cardiac pump dysfunction. So there is an issue or a problem with pumping the blood to the outside of the heart. So this is that's why we get congestion and low perfusion. So we get congested heart and also low perfusion to the vital organs or any other organs. So symptoms include symptoms of any heart failure, whether it has basically two types. So even though they're different, but the symptoms mainly include for both of these dyspnea, that is shortness of breath, and also orthopnea, a problem with breathing and having shortness of breath at night when someone tries to sleep, and also fatigue. And of course, within the signs, when we check the patient for signs, we're going to listen to S3 heart sound that is to be heard at the early diastole, and also we may hear rails, and also we may see JVP distension, so jugular venous distension, and also pitting edema. This is something that we're seeing here. So we press for a little while on the patient, on the shin of the leg of the patient, and we can see when we lift our hands up, we can see this indentation stays in there. That is the pitting edema. So, regarding the function, like what is the problematic function now? It may be divided into systolic dysfunction and also diastolic function. But if it's regarding the site of the main problem, it may be due to the left heart failure or right heart failure. And of course, there are like other classifications, but what is mentioned in here is the systolic dysfunction, diastolic, and also left heart failure and right heart failure. So the systolic dysfunction, it's basically heart failure with reduced ejection fraction. So heart failure with reduced ejection fraction. Okay, so it's just as the name implies, there is an increase in diastolic volume, reduced contractility, often most likely secondary to ischemia or myocardial infarction. So there is an area of the myocardium is already dead and not working. That's why we get the reduced ejection fraction. And also one of the reasons could be dilated cardiomyopathy. So basically what is happening here is that the heart cannot pump all the blood that needs to be pumped because part of that ventricle that is pumping is already dead, or probably that ventricle is already dilated, so it's not working properly. That's why we see there is an increase in the end diastolic volume. So there is a lot of blood existing in the ventricle at the end of that of the diastole, okay, because there is blood from the new diastole that is happening, and also there is blood that has been there, like left there from the last systole that the heart did or undergone. So we also of course have reduced contractility. So because as we said, it could be ischemia, MI, or dilated cardiomyopathy, so it loses its ability to function properly and there is reduced contractility. So that is for the systolic dysfunction. Now for the diastolic dysfunction, it is a heart failure with preserved ejection fraction. So heart failure, okay, this is cool. This is heart failure with preserved ejection fraction. We can see normal and diastolic volume, but a problem with the compliance of the ventricle. So there is a reduced compliance, which means an increased end diastolic pressure this time, not volume. So it's not about the amount of blood that that stays in there. It's the pressure of that fluid or that blood in our case, because we're talking about the heart, the pressure of that blood on the walls, because these walls have lost their capacity to be compliant, to be more flexible. They're just lost their compliance. So that's why we're not having any problem with the contraction of the heart, with the pumping of the heart. It pumps completely fine, but when it fills, it needs a certain amount of compliance, which we have lost here. So this happens most likely secondary to myocardial hypertrophy. So, if a patient has myocardial hypertrophy, most likely is going to get a diastolic dysfunction, diastolic heart failure. So, now it says that right heart failure most often results from left heart failure. Well, makes sense because we know that this is the heart, this is uh, the left atrium, left ventricle, right atrium, and right ventricle. So, why is it looking this way? Okay, so the veins coming here are coming from the lungs. Okay, there you go. And the artery going from here is going into the systemic circulation. And the veins coming to here is the inferior vena cava from the systemic circulation. Okay, that's superior and inferior vena cava. This is coming from the systemic circulation. This is systemic circulation. It goes this way, and the right ventricle ends as pulmonary artery that goes to the lungs again, and then from the lungs to the left atrium. Okay, so now that's how we see the problem. If basically the problem with the right heart failure is mainly caused due to an actual problem within the left heart failure. So a problem within here would end up, this happens first, and then second we have the right heart failure. So it's all because it's all connected to each other. So um, the blood that is going from the left side is actually going to systemic circulation, and then it's just going back into the superior and inferior vena cava, and then from superior and inferior vena cava into the right ventricle, and then from here into the pulmonary artery, from the pulmonary artery then to the lungs, and then going back. So it's because it's all connected. So that's good to know. Right heart failure most often results from left heart failure, but also we have a condition called pulmonale. Cor pulmonale refers to an isolated right heart failure. So a problem over here is only due to the right heart failure, only here. And it happens because of the lungs. So our main problem here is the lungs. So if the main issue is the pulmonary cause, then we will end up as right heart failure, and that is called corpulmonale. So the treatment that we can use are ACE inhibitors, ARBs, and angiotensin receptor neprilysin inhibitors, beta blockers, except, that's important. Beta blockers, we can use them, of course, in heart failure, except in acute decompensated heart failure. Just in that case, if it's acute, if it's decompensated heart failure, which means like the body has lost its ability to overcome the heart failure. So the heart failure symptoms, they just show immediately and really fast. That means the body cannot handle the heart failing anymore. So it just gives up, and we see the patient in an acute condition. So that's called the acute decompensated heart failure, in which we cannot use the beta blockers. So what we also can use is aldosterone receptor antagonists. They do reduce the mortality in the heart failure with the reduced ejection fraction. So the type one, that is the systolic dysfunction. We can use these aldosterone receptor antagonists. Also, we can use loop and thiazide diuretics, and they are used mainly for symptomatic relief, so they don't actually change the course of the problem or the end result, they only deal with the symptoms. These are the loop and thiazide diuretics. Also, hydrolyzine with nitrates therapy improves both symptoms and mortality. So these two are, let me say, perfect. Hydrolyzine and nitrate, they both deal with the symptoms and mortality in select patients. Okay, so now for the left heart failure, uh, well, let me draw a better image over here. So this is the heart. Okay, this is not a nice heart. If this was the heart, this is left ventricle, this is left atrium, this is right atrium, this is right ventricle. Okay, so from the left ventricle goes out the aorta, and then from the right ventricle goes out the pulmonary artery, and from the right to the right atrium comes the superior vena cava and inferior vena cava, bringing the blood from the systemic circulation from all parts of the body, and then the left atrium gets its veins from the lungs, so it's bringing oxygenated blood into the left atrium so they can go over here. Okay, so what is happening in the right, in the left heart failure, patients may feel the orthopnea. Orthopnea, that is a shortness of a breath when in supine position. So when someone is trying to lie down, like trying to sleep, what will happen is that due to gravity, if the patient, so this is the patient standing, if they do this and in the supine position, that means the gravity affects all parts of the body at the same time, and that mainly would lead to redistribution of the blood. That is the immediate gravity effect, and in because it redistributes, it would increase the venous return from the distribution of the which exacerbate increase in venous return exacerbates the pulmonary vascular congestion. So basically, what is happening here, due to this redistribution of blood, it will end up as increased venous return to the heart, and that will increase exacerbate the pulmonary vascular congestion. So the increase in the superior vena cava and inferior vena cava blood flow into the right atrium over here, that is due to the immediate gravity effect. So there is more blood in the right atrium, which means more blood going into the right ventricle, and also more blood going into the pulmonary artery. So the pulmonary artery normally takes the blood in order to oxygenate it into the lungs. Okay, so we have two lungs over here. Oxygenation goes on fine and everything is fine, and then after oxygenated oxygenation is done, these lungs send their blood back into the pulmonary veins, which goes to the left atrium. So if we have a problem, and this is something that we have here because we are talking about the left heart failure. So since all of this fine, this is fine, increased a lot of blood in the superior inferior vena cava, a lot of blood in right atrium, a lot of blood in right ventricle, a lot of blood in pulmonary artery, and then blood gets oxygenated in the lungs and goes back to the left atrium. But here we start having a problem because this patient already has a left side heart failure. So the blood gets to this point and it just gets startled because it cannot flow completely fine in the left side of the heart, which means it will unfortunately backs up into the lungs because this side of the heart is um, is failing. this side of the heart is not functioning as it's supposed to. So basically, it will go back to the lungs instead of going into the right atrium. Of course, some of it goes into the left atrium, but most of it gets back to the lungs. And here, these lungs have a lot of blood transidating, a lot of fluid transidating, and this fluid is what is causing the orthopnea. So this is the reason why this patient gets shortness of a breath in patient who has left-sided heart failure. So this is the problem because the blood backs up and goes again into the lungs. Okay. For the paroxysmal nocturnal dyspnea, it is a breathless awakening from sleep. So it's basically the same thing because there is an increased venous return from redistribution of blood, and also in addition to the redistribution of blood due to the gravity, there is reabsorption of peripheral edema, and it's basically the same mechanism. So a lot of blood is going through the superior inferior vena cava, goes to the right atrium, then right ventricle, then goes to the pulmonary artery, and it's fine, and then gets oxygenated in the lungs, and it's fine. The patient is asleep, and then it's supposed to go oxygenate the blood from the lungs to the left side of the heart, but then the problem starts, and this it gets shocked because the left side of the heart is failing. So unfortunately, it needs to back up into the lungs and cause this paroxysmal nocturnal dyspnea, and the patient starts awakening breathless um, at night or during sleep. And also there is pulmonary edema. So there is an increase in pulmonary venous pressure, and that is due to pulmonary venous distension and transudation of fluid, and there is presence of hemosiderin laden macrophages, and these are called the HF cells in the lungs. So basically you somehow the same mechanism, but what we are actually seeing is that there is an increased pressure in the pulmonary veins. So these are the pulmonary veins over here. They're attached to the left atrium, and also we can consider the small capillaries surrounding the lungs. So they do have now high pressure because of the backup of a blood into them, and of course because there's a lot of blood in these vessels, so they start transudating because the blood within them has some hydrostatic pressure, and it starts pressuring on the vessel wall and starts exiting the vessel wall into the interstitium, and now we started to have pulmonary edema. And in this case, we can see what is called a hemosiderin laden macrophages, and these are called the HF cells in the lungs. So that's for the left heart failure. Now, for the right heart failure, what we can see is congestive hepatomegaly, and that is due to increased central venous return, and there is increased resistance to portal flow, and rarely this leads to cardiac cirrhosis associated with nutmeg liver, and that is the mottled appearance on a gross exam. So in the right heart failure, if we draw heart over here, so this is okay, this is too big. This is a okay, this is a weird heart. Okay, so this is the left atrium. So if we try to draw their heart here, there is a left atrium, there is left ventricle, there is right atrium, there is right ventricle, and this one has the pulmonary veins coming from the lungs, okay, and this part has the aorta that is taking the blood into the systemic circulation, and then there's the right atrium that has blood now coming from the superior vena cava and inferior vena cava, and the right ventricle has the pulmonic artery that goes into the lungs, both lungs. Okay, so what is happening is that the inferior vena cava and superior vena cava are taking blood from the upper part of the body and the lower part of the body. So the inferior vena cava is actually taking blood, for example, from the liver, from the intestine, of course, from the, I don't know, like legs, everything. So all of that flows into the inferior vena cava. So so normal conditions of the blood coming from the hepatic circulation, from the liver, from the intestine, legs and kidneys and everything else below, and from the head, of course, it all flows into the right atrium. And then here's the surprise over here. Now we have, there is a pre-existing condition where we have a right-sided heart failure. All of this part of the heart is already failed. So this blood just gets startled and shocked and doesn't really flow easily over here. So unfortunately, it starts to backflow into the inferior vena cava and into the superior vena cava, but mainly it will show into the inferior vena cava. Well, that's why we will see sometimes a cirrhotic liver. Cirrhotic heart, no, it's a cirrhotic liver. That's why we sometimes see it. It looks mottled appearance, which means it has like this is the liver, teeny tiny dots of blood vessels, on the surface. That's how we know it's mottled appearance. It's called nutmeg liver, and it's due to the right side heart failure. So the blood cannot just go easily into it and backs up into the liver, and this is what we have now. So yeah, that's what causes the congestive hepatomegaly. So we also have the jugular venous distension. Jugular, well, it's basically the same thing because the blood from the head, neck, and upper extremities needs to go into, like the venous blood needs to go into the superior vena cava and then into the right atrium over here. But it just gets startled and shocked because it sees like this side of the heart is not working properly. So it needs to back up into the superior vena cava. And if it goes into superior vena cava, it will, of course, end as jugular venous distension. So that's due to the increase in venous pressure. Also, we may see the peripheral edema, like we have seen here. So this is peripheral edema. It's because this as I said here, the legs are attached to the inferior vena cava. So when the blood backs into the inferior vena cava, it stays within the vessels of the legs, and the vessels of the legs, of course, have hydrostatic pressure within them. So blood starts exudating these vessels into the interstitium, and now we have edema into the legs or hands or whatever. It's just peripheral edema. So that is due to increased venous pressure, which means an increased or the ending up as fluid transudation. So now if we want to take a look at the this diagram over here. So if you go one by one, delete all of this. So basically what we're having, so this is the body's ability to compensate for the heart failure. So this is what does the body do in case it notices that the heart is not pushing as much as it's supposed to. So if the body senses that the cardiac output is reduced, the heart is not pumping well, it will activate two parts. It will activate the first system. It's a process through the kidney, then the lungs, and then affecting the vessels. But mainly, the first step is activating the renin, angiotensin, aldosterone system. So this is one, and the first thing it's like that happens, but simultaneously at the same time, what is happening also an increase in the sympathetic tone. So decreased cardiac output will lead to two things at the same time. One is the increase in renin-angiotensin aldosterone system, and the other one is the increase in the sympathetic tone. So we know that the increase in the sympathetic tone, of course, can be done through the catecholamines, okay? So the catecholamines, of course, they affect either the beta 1 receptor or alpha 1 receptor. So these are the parts that are going to be activated in the increase of the sympathetic tone. So the catecholamine beta 1 receptor and the catecholamine alpha 1 receptor. And of course, each one of those has its own like mechanism. The beta 1 receptors increase the contractility, and also they increase the heart rate. The catecholamines, if they work on the alpha 1 receptor, they will affect the vasoconstriction. They will end up as vasoconstriction. So this what happens when we activate or increase the sympathetic tone. Okay, we will end up increasing the contractility, increasing the heart rate, and causing vasoconstriction. So for the other system that we just said that was activated, it will also end up doing two things mainly. The first one is angiotensin 2 is activating the angiotensin 2, and also through the V1 receptor, and the other part it affects the angiotensin 2 aldosterone ADH through the V2 receptor. So we have two places here occurring. The first one, like the V1 receptor, ends up doing vasoconstriction as well. So vasoconstriction is happening due to the catecholamines effect on alpha 1, and also due to the activation of the renin-angiotensin uh, aldosterone system over here through the V1 receptor. So this is the first part, also ends up doing constriction, and the other one is increasing the circulating volume. So this ends up increasing the circulating volume. Increase in the circulating volume itself will end up as over here as increase in venous return to the heart, of course, because now more blood, or more fluid, not definitely blood, like blood with all of its contents, is floating all over the body. That means a lot of blood now is going back to the heart as a preload, and that of course will increase the stroke volume, because now the blood has more blood coming back to it, so it has more blood to pump out. Okay, so I guess basically this is it. So what in also has increased the stroke volume, like two parts: increase in contractility due to the sympathetic activation over here. It also increases stroke volume, and we have just said that the increase in preload also. So there have two effects on increased stroke volume. So if we have an increased stroke volume over now, that means we have maintained successfully the cardiac output, which is great. Now we've done cardiac output really great. So in addition to the increase in stroke volume, the increase in heart rate has helped us doing so. So now we have an increase in heart rate, as we said, due to sympathetic activation, and we have an increase in the stroke volume. So that all leads to maintained cardiac output. Is that it? No. Actually, the vasoconstriction that we have just talked about has done two things as well. It has increased venous tone, which also the increase in venous return has helped in. And also, this vasoconstriction caused increased arterial tone. So it's, of course, a vasoconstriction. So basically, the vessel is getting smaller, which means we are increasing the tone of the arterioles and arteries. So if we have this increased tone, now we have maintained the blood pressure. And if we maintain the blood pressure, it means we also helped in maintaining cardiac output. And wow, that's it. Well, what this process is called on the two parts of it. So the very first things like that were activated is neurohormonal stress. So the neuro part is this increase in sympathetic tone. It affected the neural system. while the hormonal stress has affected the renin, angiotensin, aldosterone system. So this is neurohumoral, this is a neuro, and this is a humoral stress. Okay, but both of these have made us go to the second part of the process that is called the hemodynamic stress, because this is what happening uh, um, with the body, not just on the neural level or the hormonal level. This is what is happening within the vessels and the blood itself. So this is what happens regarding maintaining the cardiac output. But because all of this happening more than it should, because we have reduced cardiac output, because it's happening as a response to a problem. So of course it will lead to an increase in that problem, like to be make it even a bigger problem, because all of these neurohormonal stresses and hemodynamic stresses, it will end up as deleterious cardiac remodeling, also aiding and helping in decrease of cardiac output. So it's just a non-stop circle. Each one of those causes the other, and the circle keeps on going. That's why we need medications in order to help this patient or slow down this process at least. So we have already talked about these diagrams before. So what we have here is the in the heart failure, and the heart failure with reduced ejection fraction. So we have a systolic dysfunction. What is happening here? There is a problem with the black line. All of this black line is the normal cardiac cycle for one heartbeat, and it's fine. But the pink color is the abnormal, and that is due to the reduction in the contractility. So basically, this is the curve that is changing during a systolic dysfunction. So this is the systolic curve, and in case of reduced contractility, this is contractile. The contraction now is reduced. So this is a heart failure with reduced ejection fraction. But in the other case, the problem is with this curve, and this talks about or implies the diastolic function, which means the filling of the heart. So if there is any change, then it's related to the decrease in compliance, not in the contractility of the heart. And that should be it.